and good afternoon, everyone. I would like to thank the VTE Scientific and Organizing Committee for the invitation to present at this outstanding conference. It has really been an awesome day. So thank you very much. And when you listen to the speakers ahead of me for today, it has just been, we've learned so much. So thank you for that. So today I'm going to be talking about implementing system-wide VTE prevention. And we're going to talk about a multidisciplinary approach, but where I'm going to focus is on the pivotal role of nurses. So the outline that I will cover is the nurse's role in knowledge and skill set, risk assessment, pharmacological prophylaxis, mechanical prophylaxis, basic VTE prophylaxis, patient and family education. So when we look at the knowledge and skill set, nurses need to remember that VTE, yes, as mentioned previously, is the third most common vascular mortality worldwide and comprises of deep vein thrombosis and pulmonary embolism. Now, despite being a largely preventable condition, it remains a leading cause of mortality and morbidity and increased healthcare costs. Since VTE is a common vascular disorder with high mortality and morbidity, correct thromboprophylaxis offers a chance to decrease the overall healthcare costs and improve the safety of hospitalized patients. And this is where we come in as the patient advocate as nurses. So for nurses, we need to know what deep vein thrombosis is. We need to know that it is a formation of a clot in the deep vein, that it's a type of VTE, and that the veins that are most susceptible is in the pelvic lower leg and in the hip. And the veins are the peroneal, the posterior tibial, popliteal, and the superficial femoral. And yes, we may get a clot in the upper extremity, but the high incidence of the clot going to the lung is the highest probability is from the lower extremities. The other thing that nurses need to make certain that they are aware of so that they will be able to take care of these patients is the Virtuous Triad, which is 3 things, and this is the stasis of a venous circulation, your hypercoagulability, and the endothelial damage. When we look at the first one, stasis for venous circulation, this is when the vein valves are damaged or the veins are not used. And the patients who are at risk over here are those patients who are immobilized, have varicose veins, have had surgery, especially hip and knee. They've been traveling for long hours without moving the extremities, whether this has been air flight or they've been driving. It could be due to obstruction, it could be late in the pregnancy, especially in the 4th trimester, or due to obesity, heart failure, it could be left ventricular dysfunction, or atrial fibrillation, and there's more. I'm just highlighting the important ones here. And then you have the hypercoagulability, where this is high risk of clotting, and you find that patients who have cancer, they have severe illness, such as sepsis, they have a dehydrated usage of estrogen, such as your oral contraceptives, hormone replacement therapy, heparin-induced thrombocytopenia, as well as postpartum period, are at risk for this. The next one that we have is the endothelial damage, and this could be due to the IV drug usage, also venipuncture. It could be due to an indwelling device, the central line catheter, IV line, or the heart valves. It could be due to medication or patients who have had trauma or injury to the vessel following surgery. The endothelial damage is anything that damages the vein vessels, direct or indirect, and stimulates the platelets to start the clotting process. So nurses need to know about this here so that by the time they actually get to their risk assessment, they will have a good understanding of what they actually assessing for. Now, what we do know, and nurses play, especially your bedside nurses as the frontliners, they play a vital role in identifying and responding to the risk of VTE. Our nurses need to follow the hospital policy, the procedure, the guidelines. And as a nurse, when you do the history taking and your own physical examination, you need to use your own clinical judgment as well when you're assessing the patient, when you're looking at the extremities of the patient and you're comparing the extremities. You need to be aware of what you are actually looking at. Here at KFMC, we have the Caprini VTE assessment, which is done by the physician, but the nurse needs to make sure that this assessment has been completed within 24 hours of the patient being admitted. Also, the nurse needs to check to see that that this assessment has actually been done correctly. Now, what nurses need to remember is we are not silent partners. We are a member of the multidisciplinary team. We are certainly not, we should not be intimidated by our physician or any other person within the multidisciplinary team. What we need to remember is that we have a voice. We should be able to speak up, and should there be any concerns regarding VTE prophylaxis or the assessment that has been then you need to be able to speak up and escalate it to the most responsible physician. And as a patient advocate, we need to ensure that the VTE risk assessment is being done correctly. And as Zubaida mentioned before, the screening and the assessment, the management and the reassessment, these are all important points that as a nurse, we need to make sure that we take this into account. So yes, nurses play a really important role here. So you need to know as a nurse, if you're going to be assessing this patient, what are the signs of DVT? So just to go over it is your pain, tenderness, the swelling, the warmth, redness or discoloration, distension of surface veins, and a positive Holman sign. When you do the dorsiflexion, you find what you call the patient is experiencing a pain. Now, these are all your alerts to inform the physician that you have a concern. This is what you have noted, and you need to inform the physician, and you need to do this here immediately. Yet, not all the time do you get the positive Holman sign comes out as actually being a positive. It can be false positive, but the important thing here is that you've actually escalated this to the physician. Now, as a nurse, you need to remember that the physician is, you have mentioned this, he's going to assess the patient, but there's a few things that the physician is also going to be doing because yes, he suspects that there might be a DVT, so he's going to be doing some blood tests. And one of the blood tests that he would do is the D-dimer. So you need to be aware that the D-dimer is going to be one of them that they will do. Here you're checking for fibrin degradation fragments. And this can diagnose your blood clots, but also to remember that sometimes you may get a false positive, and because this patient has a condition such as MI, or possibly the patient has liver disease, or the patient has had heart surgery. So you have to have this at the back of your mind as well. The next one that the patient will, and then remember, when you do a blood test, it's going to tell you that yes, there is a blood clot, but it's not necessarily going to tell you where the location is. So here your physician is going to go on and then do the ultrasonography or the contrast venography. And the contrast venography is a gold standard for judging imaging methods. And this is something that you need to know, that if you want to see the location, these are the tests that the physician is going to be doing. Now, if you have a patient who has had the DVT, here you as a nurse need to be educated, and you need to educate your patients as well in making certain that they do not massage or rub the affected extremity, that they elevate the affected extremity above the heart level, and that they ensure bed rest. Because remember, if the patient has got a clot, you do not want the patient up and about, mainly because you do not want this clot to be dislodged. And here, as a nurse, you need to make certain that you know how to do the leg circumference measurement, where you will check to see that if you, when you are doing the leg circumference measurement, here you're assessing to see that if there was swelling, has this swelling gotten worse? So here we move on to the pharmacological prophylaxis and the nurse's role in this. Nurses need to understand what the pharmacological measures are going to be. And we need to know that the anticoagulants do not break up the existing clot, but helps to prevent the clot from getting bigger and new clots from forming. Then we will talk about the indirect prothrombin inhibitor, your heparin, and your vitamin K antagonist, warfarin, and how nurses are involved in this. So when we look at the heparin, your heparin enhances the activity of your antithrombin 3. The concept for nursing to remember here is that this is fast onset, it's given intravenously, or it can be given subcutaneously, and it's weight-based. Now, the most important thing here for nursing is that you have to make sure that the patient has the current weight so that the physician can go on and order the medication correctly. Here we will be monitoring the APTT, and this is your activated partial thromboplastin time. And it has to be 1.5 to 2.5 times the normal range. Now, nurses need to remember that if it is more than 80 seconds, that here your patient is going to have an increase in bleeding. And if it is less than 60 seconds, that here that is not within the therapeutic range, and here your patient can actually start to deform more clots. So, which means that both of these actually need for escalation to the physician so that we can make absolute certain that the patient starts to receive the correct amounts and the doses, or we need to stop the infusion for a short while. So, your communication with the physician is extremely crucial, and this has to happen in real time. And then for nursing, just remember that your protein sulfate is the antidote. We next talk about the Texan, which is your enoxaparin sodium, and that's your low molecular weight heparin. This is administered by subcutaneous injection under the subcutaneous layer of the skin. It is given in the abdomen, and it is 2 inches away from the umbilicus, so it's around the umbilical area. It can be given on the lateral aspect of the thighs and the arms, but here you need to make absolute certain that you do not put it into the muscle. For the nursing considerations here, nurses need to remember that you do need to select the appropriate site, you do need to alternate the injection site, and you do need to pinch the skin fold while injecting. Nurses also need to remember that you don't rub the injection site, as this may cause bruising. You do not expel the air bubble from the syringe prior to injection to avoid loss of the drug. You don't inject into the bruised or scarred areas. You don't release the pinch until the needle has been withdrawn from the skin. You don't aspirate after inserting the needle during administration, and you certainly don't administer this intramuscularly. This is a subcutaneous injection. It must be given into the subcutaneous layer. And remember, nurses need to know that if you're going to give this here into the muscle, then you're going to end up with having bleeding. You may have bleeding in the muscle. Again, your antidote is your protein sulfate. We now move on to the vitamin K antagonist, and here you have warfarin, which is inhibits the clotting factors from using vitamin K. The concepts to remember here is that there's a slow onset given orally, and here nurses need to remember that they're going to be monitoring the PT and the INR. Your PT is your prothrombin time, your INR is your international normalized ratio. Now, the INR, in order for it to be in the therapeutic range, it needs to be between 2 and 3. So nurses need to know this. You also need to know that if it is more than 3, if it's greater than 3, then it means that the patient is more at risk of bleeding. And if it is less than 2, that this patient, which is not within the therapeutic range and obviously can form more blood clots. Here, the antidote is your vitamin K. The INR level must be available before the administration of the warfarin. So this is something as nurses we need to know. We need to make sure that the physician is aware of what the INR level is. Here we use the international administration time, and that is 5 p.m. Next, we move on to thrombolytics, and this is something like, for example, our acute stroke nurses will see this here, where they have thrombolytics is the catheter-directed clot-busting agents like the TPA. And here, the important thing that nurses have to really look out for is the bleeding, because these patients are at very high risk of bleeding. Now, nurses, when we spoke about the pharmacological prophylaxis, you also need to remember that this medication, it has to be given on time. It has to be given as it has been prescribed by the physician. Your role in making sure that you keep this patient safe is extremely crucial. If a patient is non-compliant and is refusing to have the anticoagulant, you have to escalate it immediately to the most responsible physician. So you need to understand that you do play a very important role in this. The next one that we talk about is the mechanical prophylaxis. And here we talk about the anti-embolism stockings, which supports the healthy blood circulation. The pressure that these stockings put on the ankles and legs compresses the surface arteries and veins, helping the vein valves to function properly and the blood flow back to the heart without obstruction. Here we need to follow the physician order, and here at King Fahd Medical City, we do have a very clear policy with with a great algorithm. It tells you exactly what you need to be doing. So you have your protocols, you have your guidelines. These are things that you need to follow. You need to measure the patient's ankle, the calf, the thigh to ensure that this year the correct size and the correct fit. You need to ask the patient if they are experiencing any tingling, numbness, coldness, pain, or swelling, as this may indicate that the stocking is too tight. You need to smooth out any wrinkles, otherwise they will dig into the skin or underneath and cause the tissue damage. As nurses, we need to inspect the skin 2 to 3 times in the day, and remember that the stocking should be removed daily for hygiene purposes and to inspect the skin condition. The next one that we have is the pneumatic compression. The intermittent pneumatic compression devices are used to help prevent the blood clots in the deep veins of the leg. The device uses the cuffs around the legs and they fill with air and squeeze the leg. So here we need to make sure that it also is the correct fit. We also need to know that it increases the blood flow through the veins of the legs and helps to prevent the blood clots. And again, we need to take care of the patient hygiene. Nurses to keep in mind that if a patient cannot take anticoagulants and there is progression or recurrent DVT, and here a lot of the ICU nurses will know about this. Here is the Ibc Filter, which is a small metal device that is placed in the inferior vena cava, and this is to prevent the blood clots from entering into the heart and lungs. So you need to have the background knowledge. And then we move on to basic prophylaxis. And the first one is the ambulation. This stimulates the circulation, which can help stop the development of blood clots. And nurses play a really important role in early mobilization. We as nurses need to remember that we were the patient. Actually, if you look at the amount of time that we spend with the patient, it is the longest from all of the rest of the members from the multidisciplinary team. We were the patient 24/7. We work 12-hour shifts, which means that we should pay attention to what is happening with the mobilization. These patients need to be mobilized. We need to make sure that we help mobilize them. And yes, your physiotherapist is going to see the patient when the patient is first referred. You also need to pay attention on what the physiotherapist is teaching the patient so that we too can help mobilize this patient safely. Because remember, what the physiotherapist is also teaching the patient is something that where nurses can also carry those skills back to bedside and sit your patient out in the chair, mobilize your patient, make sure that your patient is safe. So that ambulation can be continuous. We don't have to necessarily wait for the physiotherapist. The next one that we talk about is bed rest. And here we talk about the elevating the patient's legs can help to instantly relieve the pain, instructing the patient to elevate the leg above the heart 3 to 4 times a day for about 15 minutes at a time, as this can help reduce the swelling and improve the venous return. And then we talk about exercise and lifestyle. Here we need to make certain that we are aware that clotting is often caused by long periods of inactivity. So practicing a regular exercise routine and healthy lifestyle can help to reduce the clots and other conditions related. And then crucial, and Zubeda mentioned this here early, was the patient and family education. We are talking about VTE prophylaxis, and we're talking about VTE prevention. The patient engagement is crucial. How do we get the patients engaged? Nurses need to be able to give them that health education, Number one, about their medication. Teach them and inform them that they prescribe about the prescribed anticoagulant, its purpose, and the need to follow the regimen. Inform the patients that they will have periodic blood tests and are necessary to determine if there's a change in the medication or the dosage if required. Encourage this patient to drink plenty of fluids and explain to them why they need to have the fluids, unless, of course, it is contraindicated. Activity, explain to the patient the importance of the ambulation, the elevation of the legs, doing the range of movement exercises. And then, of course, the patient's living a healthy lifestyle and exercising. So informing the patient about the importance of having a healthy diet and how they themselves can actually contribute to VTE prevention. So in conclusion, what I would like to say is that research conducted worldwide significantly supports that nurses play a pivotal role in thromboprophylaxis. It is essential to recognize the necessity for education about VTE among our nurses and explore various factors that impact nursing care at the bedside. I totally agree with Zubaida because nurse leaders and nurse educators can certainly assist in determining nurses' knowledge of VTE prophylaxis, understanding the gaps in knowledge, and the skill set in enhancing safe, quality, and person-centered care at bedside. So these are the references, and I would like to say a sincere thank you for this time to actually share with you the pivotal role of nurses. Thank you very much.